Hi, I'm Sheila Reyes from the Philippines, and I'm recording for you now here in beautiful Fukuoka for APLAR 2025. Neuropsychiatric SLE or NPSLE is a complex condition that presents with a broad range of neurologic and psychiatric manifestations that can involve both the peripheral and the central nervous system. In this video, I will share important highlights about Dr. Alberta Hoy's talk on demystifying NPSLE, in particular, diagnostic challenges, role of objective assessments, and important differential diagnosis. Attribution models in the context of NPSLE guide clinicians by helping them determine whether a neuropsychiatric event is caused by SLE or another disease entity. According to Dr. Hoy, despite available definitions, there are still pitfalls in nomenclature, and there's really no gold standard for the diagnosis of NPSLE. As she describes, overlaps can also occur, like in cases where an SLE patient would present with demyelinating symptoms. It's really difficult to differentiate between which is which. And so an overlap with neuromyelitis optica spectrum disorder or NMOSD may exist. She emphasized that the use of objective assessments in both the acute and the chronic settings, such as imaging, serum biomarkers, CNF analysis, should always be attempted. Another insightful aspect that Dr. Hoy highlighted with respect to biomarkers was that the use of conventional biomarkers like your APLs and anti-ribosomal P antibodies are by associations only, and positivity doesn't necessarily mean a diagnosis of NPSLE. In contrast, the serum anti-aquaporin 4 antibody, a novel biomarker, is highly specific for NMOSD. This condition can have a substantial diagnostic overlap with NPSLE, especially in the presence of other antibodies, autoantibodies, and organ manifestation. Additionally, CSF analysis is essential to exclude infection, and factors that increase the likelihood of CNS infection may include high fever, high opening pressures, high CSF TMN ratio, and a low CSF glucose. Another important disease differential for NPSLE mentioned by Dr. Hoy is PRES, or the posterior reversible encephalopathy syndrome. It is an acute neurological syndrome clinically characterized by headaches, seizures, and hypertension with imaging findings of reversible parietal occipital edema. Observational studies and even with experience with a patient of mine also show that stress can occur in the setting of active SLE for which immunosuppressive therapy is required. How can these new learnings help us in clinical practice? I think as clinicians, our clinical judgment remains the most important tool in diagnosing and treating our SLE patients. The use of objective assessments can significantly aid us in proper decision making, particularly in managing complex conditions like NPSLE. Follow me on X at Rumarampa and tune into Room Now for more updates.